Okay. So again, I'll just end about 5 minutes early, and I'll make sure the lecture is uploaded promptly to the website. Okay. All right. Let's see here. Okay, can you guys online give me a thumbs up if, or a text or a chat if you can hear me and the screen is visible? Somebody type it's okay. Okay, great, thanks. All right, so we're about a third of the way through at this point. I'm going to turn down the lights a bit. And so we've done nuclear medicine, and those of you who did 280A also know CT and MR very well. We have ultrasound ahead of us, but in the middle here, we're going to start looking at some of the techniques used for testing the difference in performance between different imaging modalities. Okay. And there's a number of papers. We'll look particularly at 2 papers in this lecture, which show how the different imaging modalities affect patient management all the way to the end, even to survival differences. Okay. And so this is sort of the first shot at sort of labeling all of the techniques or giving you all of the techniques that you use to test the performance of different images. So at its most basic level, the things that we can measure quite easily in one imaging modality versus another, and which one is, say, achieving a better number, a better result, are these things that we've looked at in image quality, right? So it's, can you resolve 2 small objects, spatial resolution? What's the difference in signal between your target and the background in which your target is going to appear? So your target might be a tumor, your target might be coronary calcium, can you detect it? A coronary lesion in a vessel, a hairline fracture in a bone, can you detect that? Those are your targets. And what is that signal in its background? And so there's very simple contrast to noise, and then there's also clarity of the picture. Is there a lot of clutter that confuses your read of the target? And we'll see an example right at the end of this lecture where it's not simple to read an image because there's so much going on in the image. Then how do we minimize the noise? The most fundamental way to minimize noise is to average. So if you took 10 versions of that picture and average them together, they should get better in terms of signal to noise, because the signal will add up as n, where n is the number of instances, and the noise will add up as root n usually, and so the ratio of those 2 goes up, right? And that's the signal to noise ratio. And so if you haven't got enough signal to noise, the easiest way to get more is just to take 2 pictures and average them together, right? The problem with that is sometimes the 2 pictures aren't exactly the same. So if the patient's breathing or if their heart is beating, etc., you can't just average them together. You have to do some kind of correction to average them together. Everything that I said for signal to noise is true for contrast to noise ratio, which basically is a 2 signal problem. It's like target, my background, and what's the signal difference divided by the noise. And then we looked a bit at temporal resolution, which is how long does it take to take a picture? Are things resolvable which are moving? And so in nuclear medicine, we saw it took minutes to collect the signal, all of the projections required to make a picture. And so if that thing is moving, the temporal resolution has also messed up your spatial resolution, because your temporal resolution isn't quick enough, right? Whereas with your, if we're taking X-ray fluoroscopy, we can, in a few milliseconds, grab enough data to make a picture. And so it's like having your camera set at 1/500 on the shutter. Like, you guys probably never even adjust shutter speeds or anything anymore, but versus a 1/4 second on your camera. Does anybody ever use an SLR camera in here where you set the f-stop and the speed of the shutter? No, that's an art that's gone. Yeah, because the engineers at Apple or whatever have made your phone so smart, it just does it right for you, right? So, and remarkably, it does depth of field now, which is really cool. Digital depth of field in professional mode, right? Okay, so fundamentally, when you're sitting there as a radiologist in a hospital, hundreds of cases go across your desk, your display system, and you have to dictate out a call using these pictures, right? The pictures don't just arrive and then you figure out like, well, what could they want from these pictures? They arrive with a question. Okay? And so what comes in is a set of pictures that have been taken, usually to answer a specific question through experience, right? And so the question can be extremely simple. Sometimes it's one word with a question mark, right? Embolism, question mark, right? And here's an example of some of those questions. Does this patient have a primary tumor in their brain, right? So I'm going to do MR, I'll do contrast MR, and I'll look at high resolution pictures through this person's brain to find out if they have a tumor. And they might have wound up at the hospital because, they've got some part of their visual field that seems to be missing, right? And so they tell that to the physician. They go, well, let's check this out, and they'll just do a really high resolution picture of the brain, right? Millions of scans are done looking for breast tumors because they're so common, and so that is mammography, which we won't take in this class, but it's a super high resolution X-ray picture of a compressed breast. Like, they compress the breast, they shoot X-rays through it, and they take a picture, and so you sort of have a half dome like that. And then the physician has the unenviable task of looking through a very complex field of signal and saying whether or not there's a tumor in there. It's a terrifically hard job. I'm sure deep learning will improve the performance, but it's a simple question, and it's a binary answer, right? And so it's all this technology comes in with spatial resolution and signal to noise and all this, and it comes out with a 1 or a 0, right? Is what pops out at the end. And you can see the rest of the questions. There's thousands of these questions, and radiologists become good at all 1,000, right? And radiologists are quite remarkable in their depth of knowledge of medicine, because they have to know all freaking medicine, right? So they know lots of rare things, that happen to people because they take these on tests. You might see 4 of these in your life, but they have to remember them, right? Those are called zebras. And when people are younger, they're more enthusiastic about calling things zebras, right? Saying, oh, I know what that is, it's the following. And then their senior colleagues beside them say, you're only going to see 4 of those, right? Is this one of them? You better be sure. So that's the setup, right? And part of the whole process is getting the right people in line for that test. And we'll look at that a little bit. Like, is this the correct test for this disease? And then, is the right group of people coming into the clinic to be tested for that disease? You don't want just a random group coming in. They should be prior probabilities. So there's this paper in radiology which outlines bias in clinical trials of imaging systems, and you can rig a clinical trial such that your imaging system looks really good, right? And because people are usually enthusiastic about their technology, it's really hard not to rig it because you're just you've got this natural bias that you want the thing to do well, right? It would be nice if it does well. And so you wind up sort of with a specialized selection or something of patients that the thing does well on. So there are these levels of efficacy of a imaging test. And the technical ones are easy. Up top, we can evaluate what are the optimal parameters to choose to select or to detect something, right? And what is the protocol you should use to detect something? And then given that protocol, what are your fundamental image quality things like the resolution and the noise? And do you find that sufficient for the clinician to be happy with reading those pictures? Usually that's what it boils down to, is you test, you balance dose versus image quality, you balance temporal resolution versus signal to noise. And then you look at all of these different options. It's like a smorgasbord of pictures, and you say to the radiologist, which one would you read? And they just pick the one they want to read, right? Because they're confident in reading it. You can do that also with a deep learning algorithm or something as well, right? And then the next level up is you evaluate, given the patients have come in, and we'll look at the definitions of sensitivity and specificity and accuracy, right? And the mechanism that we'll use to evaluate the relative efficacy at this diagnostic accuracy level is a thing called the receiver operating characteristic curve, or ROC curve. This occurs in many fields, not just imaging and radiology. It's any signal detection process usually has an ROC curve associated with it. So, if you have some listening device and the listening device is looking for, correlated signal, like say you put a radio, telescope together and you look at the heavens and you're looking for any kind of correlated signal other than background radiation, right? Is there something out there putting out correlated signal like A440 for Hellas, like, just anything? Very interesting thing is there's nothing. They've looked for as long as they can look, and there just seems to be nothing coming this way, right? Which is, this is way off topic, but it's a little weird, right? Don't you think there'd be one correlated beep or something coming at us? Nope, nothing, right? So it's kind of I forget whose paradox it is, but somebody's paradox. And then after you have those performance characteristics, then you go up into, does this affect the trajectory of my patient, right? And, it's after you've done the test, if you get a negative or a positive, what does it do to their probability of having the disease? If it only clicks it up a few percent, is it worth it? If all of the clinical signs and symptoms put this patient at, say, 85% probable that they have this disease, and then you do an imaging study that takes it to 87% and it costs $2,000, is that worth it? Probably not, right? So that's like, how does it change their post-test probability? And does it actually change the diagnosis? This is the one that you see kind of heroic calls when people get the diagnosis right that other people didn't expect. It happens in radiology, and in fact, radiology is absolutely essential to every hospital now. People come in the ER, they don't know what the hell's going on with them. By the time they get out of radiology, they know exactly what's going on with them usually, right? And then in a population, so now I'm, say, Medicare, or I'm Kaiser, or I'm United Health, and I say, well, in my population of patients, did it change the group? Does this group now have a higher life expectancy? That's a huge thing, right? And so that's sort of on a society level. So we've come all the way from what's the best TR for this imaging sequence to, does it change the life expectancy of my people, right? And so this whole cascade of importance, you find in technical journals like medical physics, all of this stuff is evaluated as research, and they publish this stuff, right? And it's easy to do, and it's easy to get it like precise and everything. This stuff is super expensive because you need to put it in the clinic. People need to do it the same way in every clinic, and you need to get a big enough number to figure out whether or not we get stuff like this, like quality of life adjustment. And then cost effectiveness and cost benefit. This is virtually impossible to do. I tried doing it once. I had a very smart graduate student learn how to do this. And our conclusion after 6 months was this is just random noise, right? You can't really do it. So let's recall the example trial, or the paper that I did with that 15-minute talk, was this thing called the PROMISE trial. And it was a very direct, pointed comparison between one imaging modality, which was computed tomography angiography of the coronary vessels, versus stress testing. And stress testing meant, in the vast majority of patients, stress testing was nuclear medicine, the exact thing that we studied a couple of weeks ago. And you remember these results perhaps in that this part here is where we're getting our specificity and sensitivity. We'll look at the definition. It's like these people are called normal, these people are called abnormal, and if you're called abnormal, you go to the next stage of care, which is go to the cath lab, right? So it's a big decision, not just medically, but financially and everything. Like it's like if you go down this path, you start using a lot of big resources, right? So Medicare and people like that are interested in that. For you as a patient, you don't really care about that. You care, am I on the right arrow? Do I actually have the disease and I should go to the cath lab, or am I truly normal, right? So as an individual, that's really all you care about. As a health system, that's actually not what they care about. They care about, does my group improve, right? Those are two different games. Like if you play poker or something like that, and you know about betting and betting based on the pot odds and things like that, these two games that you're playing to optimize your care and the health insurance company is playing to optimize their outcomes, those are two different games, right? And so you actually, as a smart person going to college, want to play the individual game. You want to know these odds, and you want to play your odds such that you get the right trajectory, right? Not put yourself at the mercy of a health system that says, oh, our odds are you don't get that, right? Because that's the way that goes, right? Even though the outcome of that for you could be exceptionally good. You might not know that. So anyway, I think somebody should write a paper on that. The individual odds versus the healthcare system odds, the two games and how they relate and counterexamples and stuff. So anyway, we saw that this test produced a lot more people going to the cath lab. We got 200 more people, right? However, when we looked at the result coming out of the cath lab, 170 of those 609 were actually normal. So they were incorrectly pushed to the cath lab, right? And this is called a false positive, right? We'll look at these definitions carefully. And this, the reason it's interesting to us as engineers is this tells us where should we improve the imaging modality? Like what should we focus on? If we're gonna focus on temporal resolution, spatial resolution, or whatever, what's gonna stop this from happening? How can I make this 50, right? And so the radiologist reading this looked at it and said, this person's abnormal. And it turned out in the cath lab, they disagreed, right? So in some ways, big studies like this, even though their end goal or their primary outcome is whether or not one arm survives longer than the other, it's very useful for us as engineers to figure out what we need to improve, right? Along the way, if you look at the data along the way, And we'll look at a very good example of that in a trial that came out in 2020 called the ischemia trial. This one came out 5 years earlier. And then if you recall, here, granted, we had fewer, right? So maybe 170, maybe that accounts for the difference up here, the 600 versus 400. When they go to the cath lab, oh, nope, it did not account for it because 213 of these guys were normal. So that tells you that there's some weird performance thing going on here, up here. A lot of people are showing up in here that are actually abnormal. Right. Okay, so that's why these trials are interesting to engineers as well as insurance companies and healthcare people, right? So let's, before we go further, we're gonna just refresh our memory about the normal distribution, right? This function is used throughout imaging, both to measure, say, signal to noise, right, in the background, because you measure the mean signal of, say, the background, and then the variation on that signal by the root mean square deviation in the background. And that's characterized by this function, usually. It usually looks like a normal distribution. So say this is the background, and then this is the signal that we're trying to, measure out of the background, and it might have a higher sigma value on it, which is true in something like CT, right? Where you have a higher value, that actually means there are fewer counts on your detector, because the CT map is a map of relative absorption. And when you have fewer counts, the noise goes up a little bit, right? So then you actually have a slightly higher noise at a higher value. These functions, this is the algebra for doing these things. These functions are also used to evaluate the statistics of decision-making by imaging, okay? And here, when we look at that, and we'll see an example, this could be the population that are normal, right? And this could be the population that are abnormal. And this is the probability density function of achieving this signal measurement in that population, right? So you need to, this is a density function, so you need, a little bit of span on the x-axis here, and you integrate under there, you get a number of people in that window. And so, for example, if I put my region of interest on, say something in their liver, and the people who are abnormal, that thing comes up with a measurement of 60 in the mean over the people, over 400 people, I get this probability density of the measurement of that lesion with my system. And then the background liver is this in those people. If they're uncorrelated, i.e., if I get this measurement on the lesion, it doesn't affect my background measurement, then these two things are independent processes, right? And so the mean value of the background liver would be 40, the mean value of the tumor in the liver would be 60, right? And now I can actually do statistics on how well I will do at differentiating my normal population from my abnormal population, because I've characterized it with this function. If you have this function, you're kind of done, right? In terms of figuring out your sensitivity of detecting disease and your specificity, and we'll look at those two definitions. But I just wanted to review this, especially, you should know how to create a Gaussian. These are Gaussians, are normal distributions. And then this factor out here normalizes this such that, that the total integral under the function is 1, right? The other thing let me move that here. I'm not sure if we did this in the image quality section, but when we decided what is enough signal to noise to actually detect something, so you get a gestalt of what does your signal to noise have to be in order to detect something with, say, 95% confidence, right? So 95% of the time you're going to be right when you call something positive. And in this case, say positive is there a blob there? Is the question, right? And so these blobs, these are normal blobs. These are Gaussians in space now, right? And, you know, this is a uniform background noise. So the signal to noise drops as I go from this blob to this blob to this. This is called a phantom, right? Phantom image. It's not a clinical image. It's just something that you can see. Now, if you stand back and you squint, right, on my screen anyway, I can see this blob, right? So I'm still getting there, but probably if I called that positive, I would be wrong, I don't know, 40% of the time or something, or 30% of the time. The Rose criterion is set such that you're right 95% of the time when you call it positive. And that basically, you can work this out, means that the signal to noise is 5 or greater. Okay, and that's a pretty simple way to think about it, in that if we go back to our, how do I go backwards? There we go. Go back to this and say both of these sigmas were equal. If my contrast noise, if this is the background and this is my signal, if this distance divided by sigma is 5, you can just draw that on your computer, and these two distributions are pretty far apart, right? So you can put a line in between them and you're going to do really well, right? So 5 is a very confident level, right? It's pretty high. But when you're futzing around with your images and you're making protocols and stuff, and then you pop up these clinical examples and here's your lesion, if your signal to noise is 3, yeah, you shouldn't do it, right? You should search for a different protocol, search for a different thing, because the radiologist will not want to use that. They will not have confidence in using that. So, and your deep learning network probably wouldn't have confidence using it either, right? Or just an ROI measurement wouldn't work very well. So let's look at 2 other definitions, which I think we skipped. I don't think I did. You don't really need this stuff in the background here. So this is, we're going to discuss what stationary signal means, stationary signal and noise processes, and ergodic. Ergodic's a great word. It's the only time I've ever used this word, and nobody ever knows what it means, so it's kind of a cool word. So a stationary, an image that has stationary noise, what that usually means is, if I look at the statistics of the noise in this region over here, it is indistinguishable in characteristics from the statistics of the noise over here, or anywhere else for that matter, right? That means it's stationary. So anywhere in the field of view, my probability, my point spread function, you know, my modulation transfer function over some region of interest is the same as I move that region of interest. That's stationary, okay? And so that means if I'm, say, doing a very simple evaluation of signal to noise, I can pick a background anywhere, measure my root mean square deviation of the background anywhere, and then look at my signal. So in this image, it's not a big deal, but in a clinical image, sometimes there's just a little bit of air in the background. And you want to measure the noise there because everywhere else has signal corrupting your noise measurement, right? So all of your deviation and measurement would be from the actual signal or the picture. And then over in the corner, you have a little bit of air and there's no, it's uniform. And so you can put an ROI there and measure the standard deviation of the noise, right? Another way of getting around that problem, if you're trying to evaluate the noise, is if you, for chance, have 2 images and they're identical other than the noise. So you just take 2 images back to back, subtract them. Now all the signal goes away. The only thing left is the noise, right? And the level of the noise in those 2 images is √2 times what the RMS is of the individual pictures, right? So that's a It's a nice, simple way of figuring out how to measure the noise level. We'll come back to this separate instances of images right now. In that, ergodic is a really neat concept. Say I have 1 pixel here, right? And I look at the value of that pixel, and I take 1,000 images. And then I plot the signal intensity I measure at that pixel over those 1,000 images. So I'm not moving my pixel around anywhere. I'm looking at a single pixel. I get 1,000 images. I plot its value as I move through those 1,000 images, and I get a random number, or I get a mean and a random fluctuation around the mean. Okay. When I measure that random fluctuation around the mean, that's a sigma value, right? That's that RMS value. If I get the same sigma value when, say, I did 1,000 images and I have 1,000 pixels inside this box, if I look at the root mean square deviation of the 1,000 pixels in the box and it's equal to the root mean square deviation of the 1,000 images, that process is ergodic. That's what that means, right? And so it means, when it is ergodic, it means that when I measure the root mean square deviation in the background, I'm getting a good estimate of the true root mean square deviation of a pixel value, right? In multiple, processes. Ideally, if you're measuring the statistics and the signal to noise of pictures, you actually, the ideal thing is to take the picture 1,000 times and look at the root mean square deviation of each pixel as you move through those steps. That's the ideal thing, because that is the uncertainty you have on the value of each pixel in the field of view, is that root mean square deviation. But it's very impractical, right? It takes a long time. Picture, the object can't change, etc. So ergodic, usually in simple MRI images where you have a uniform field of view and you don't do aggressive acceleration, usually those pictures have stationary and ergodic noise, right? CT and PET and SPECT, MR when it's done with radial acquisitions, and then, those usually have different noise properties in different parts of the field of view, right? And so they're not truly stationary ergodic, although oftentimes you can just, it's pretty darn close, and you can just use the measurement of an ROI. So anyway, I wanted you to know those 2 definitions. Now you do for the rest of your life, So when you're looking at the signal to noise and how it affects your ability to actually detect if something is there, you can see that in this case, a lot of these signals just flat out disappear, right? In this single instance, right? If, however, I had 1,000 of these pictures, right? And the noise on each one of those 1,000 pictures was independent. So basically it's the signal level's the same, but the noise is independent. And I blew those, and I played them as a movie, like this. A lot of these objects would start appearing, right? Because your eye and your brain averages them together as you play them, right? So it's kind of interesting. You can try that as just in MATLAB or something. So, and what that means is, like, if I have 1,000 of these and I add them up, I just get better signal to noise, right? The noise goes up as the root of n, and the signal goes up as n, right? So eventually you would see these. The same argument, if everything is stationary ergodic, goes for calculating the mean value in a bigger disk versus a smaller disk. I have many more points to evaluate the mean value of this signal than I do over here. It's truly just an n points issue. I got fewer points inside this circle, so its mean will fluctuate more than the mean value of this thing in each instance, right? So when I calculate the mean value over this many points, well, my brain can see the thing, right? And so that's why you can see bigger stuff, right? And this has you know, pretty important applications in, say, lung imaging, where you're looking for very subtle lesions, which are kind of the size of a dime or a quarter. So they're not high resolution lesions, but the contrast is really low. It's just a slight density change in the lung. And this is in smokers, for example, and that's how lung tumor starts. And you can see it and get on your horse and get in there and cut it out if you see it, and that person will live, right? If they quit smoking, probably. But the issue is they have to reach a certain size before you are really confident at detecting them and what they are, because if you go after ones that are small, if you see these small lesions, oftentimes there's two problems. It can be a false positive, right? Just through statistics. Secondly, it can actually be a little nodule that just resolves, right? It's just like an irritation in this person's lung that just was there and then it resolves. So you want to do two studies separated by some time, right? So normally that's what happens in these basically screening studies. It's been shown now that if you're above, I think it's like 48 or 50 or something like that, and you've smoked and you continue to smoke, it is worthwhile to have a CT screening study done of your lungs, because the people who get the screening study and are treated survive, and those who don't just go on to die from lung cancer. And so there's an actual measurable benefit for doing this thing, right? And that's been shown over the last 15 years in these huge trials, right? Okay, so we'll look at the concept of accuracy and precision. And you probably know this just from your, I don't know, your physics lab or whatever. But you can have something that when you take many non-reproducible measurements, right, the mean value of those measurements is right on the money, right? And so you say that, well, it has relatively high accuracy because the mean value, if I take enough measurements, will give me the right number, right? So yeah, let's call it accurate. Like, any single measurement isn't going to be that good. This, on the other hand, has high precision in that it's very reproducible. So there isn't some random noise source inside my system that's pushing the numbers all over the place each instance. Every instant is reproducible. But I'm off target. Like I have some bias in my measurement, right? For whatever reason, in my machine. This is easier to deal with, right? Because you can just calibrate your damn machine, right? And whatever you have to measure over a certain amount of instances that basically have different settings on your machine, but then you can calibrate all those so they give you the right number. This is done a lot in CT in that, and probably in nuclear medicine as well, where you put a source in the system, or in CT, you put a phantom in the system of water and other things. And then you hit calibrate, and the system goes through every energy, right? And a set of different intensity levels for the x-rays and stuff like that, and then makes a huge calibration table. And then when you take an image in a person, it goes to that calibration table that you took an hour ago and uses those values, right? And so that's to get rid of this problem. When you do that calibration, you wind up here, and you have high accuracy, high precision. And this is, of course, the worst case where you have accuracy or precision. But the lack of precision is to me, a bigger issue, right? And that the only way to get rid of that is to take a lot of measurements, right, and average them. So now we're going to define and understand this. There's actually 4 concepts here, the 2 on the title. Sensitivity and specificity. It's probably the most important concept in imaging evaluation on the technical level, right? As opposed to the higher hierarchical level where you're getting into society things. And so we can tune our imaging system and improve our detectors and change our protocols such that the SNR and CNR are optimal per unit time or per unit dollar or whatever you want, right? Per unit dose. And the question is, does it answer this question? So based on this imaging study, can you make a clinical decision with high sensitivity and specificity? So you need to map it at least that far, right? And sensitivity means when I have, say, a group of 100 people, and I have 10 of those people that are positive for this disease, high sensitivity means I get all 10. I call all 10 positive. Then I've got high sensitivity. It's like extracting all of the abnormal people out of your pool, right? However, there's a caveat, right? I can have a very sensitive technique if I call everybody positive. You just say, oh, all these people are abnormal. I'm guaranteed to select all of the abnormal people. And therefore I have high sensitivity. I didn't miss anyone. But under those conditions, I have very low specificity. So this is the complement to sensitivity is if I have high specificity, that means I also, all the people that are normal, what fraction of those people do I call normal, right? So if I had 10 abnormal people in my group of 100, when I'm finished imaging, I've called 10 people abnormal and 90 people normal, I have perfect sensitivity, specificity, right? High sensitivity, 100%, high specificity, 100%. So that's a perfect test. That never happens. You usually get some kind of crossover, right? The most common thing that occurs is in some kind of test, you have a large number of normal people, a much smaller number of abnormal people in your pool, say 5 out of 100 are abnormal, and you call 10 of your 100 people abnormal. You collected all of the abnormals, so your sensitivity is still 100%. However, now your specificity is dropped because some of the normals wind up called abnormal. And that's where the next two concepts come in. If I have called 5, I have 5 abnormals, right, in my 100 people, and I've called 10 people abnormal. All 5 are included, so my sensitivity is 100%. However, my positive predictive value, if I'm sitting in a room full of people who've been called positive by this test, there's 10 of us, what is my probability of being positive? It's only 50%. So I can flip a coin in that room, right? So the positive predictive value is low if you push your sensitivity to be higher by including normals in your call, right? And I don't know if you watch the 1 brown, 3 blue, or 2 brown, 1 blue. I put some video links there. This is a conundrum in statistics that most people don't understand, even physicians. Half of them don't understand this, is that they confuse sensitivity and positive predictive value all the time. So they'll say for mammograms, they'll set up the problem, say, okay, now a person has a positive mammogram. What's the probability they have the disease? And they will give the sensitivity number. They'll say, oh, 90%. They're like, no, it's not 90%. It's like 40%, right? So that's like half the physicians in the room. Right? It's a really good video. You should watch it. That guy's videos are terrific. I mean, sometimes you get addicted to them. You're just like, oh God, I've spent like 2 hours watching these videos, but they're really good. What is it called? 3 brown, 1 blue? 3 blue, 1 brown? Yeah, thanks. And so he spent a lot of time coming up with this graphics program to make fantastic visuals for fairly hard concepts. So that's the positive predictive value. Okay. Negative predicted value is the same thing, just if you're in the room with a bunch of people called negative, like what's your probability of being negative with all the people that got called negative, right? It's the same thing. Okay. Any question about those two definitions? 4 definitions, I guess. Okay. So now we're going to look at how these come up. I'd like to, I don't know what that is. Okay, here we go. Sorry. All right. So we're going to define sensitivity and specificity now and positive predictive value. We'll give you formulas that you can use to compute them when you do a clinical trial of some sort. And the trivial way of doing this, or the simplest way of doing it, if you can, is you have, say, 100 cases, and you know the underlying truth in each one of those cases. And you have an imaging system, and your clinician plus the imaging system become the observer response. Okay, so the clinician looks at the image, uses the image quality and all that kind of stuff to make a decision, right? And either calls it abnormal or normal, right? This observer response could be the, hello. This observer response could be, say, a deep learning network plus the images, right? It can also be just you measuring a region of interest on a signal and making a decision based on that quantitative measurement, right? Engineers love that. They love going to a system where say, all I have to do is segment things, make the measurement, and make a decision based on a hard number. And I don't need a human decision maker, right? And because at that point the statistics is simple, etc. That is rarely what is done, and there's a good reason why it's rarely what is done. Is because the clinician reads the patient's history for one thing, right? And so there's a huge prior probability coming into this decision of, oh, everything that this patient has done leads up to this being positive, right? And so that really changes your prior. And the imaging test, this test really, as you see in that video from 3 brown, 1 blue, or 3 blue, 1 brown, is, what the test does is it changes your prior probability. That's all it can do. It doesn't give you like an independent probability, because if it did, your performance would drop really low, right? Because you want to know what that prior is. So the observer, the clinician comes in with that prior, looks at your pictures, and makes the call. Underlying truth is, let's just say we're doing lung screening or something, and so it's a simple call. It's like, is this cancer or not? So if the radiologist looks through your pictures and says, I don't see any cancer here, and actually in this patient there is no cancer, then that's called a true negative call, right? Right, and in this box, we're going to put how many people are in the true negative box. They got called normal and they actually were normal. In some cases, the clinician will look, not find the tumor, and say, oh, that's normal. Actually, there was one there, right? And that's a false negative, right? So they said the patient's normal, negative test. However, that person does have the disease. And we saw that in the stress testing for cardiac disease, there's a lot of these, right? A lot of people were called normal that probably had the disease, just from the PROMISE trial results. The radiologist looks at the thing, says, yep, that's a tumor. I'm going to call that positive. However, for whatever reason, that thing isn't a tumor. It's something else, right? That's a false positive. And then here's the golden, these two are the golden boxes, right? Where you call them abnormal and there is a tumor there, and that's the true positives. So if we have 100 patients in our test, we're going to fill out these boxes, right? And we might get, 40 in here, 40 in here, 10 and 10. that would be okay, right? So we would have, 10 people got called out of the 100 false positive, 10 false negative out of the 100, and 40 and 40. That would be reasonable. If it was 25, 25, 25, 25, don't do that test because you may as well just flip a coin, right? There's no reason that you do that test. And then if it's 50 and 50, that's miraculous, right? That isn't usually going to happen in medicine or biology. So how do you come up? Remember we talked about the probability density function of a measurement in the group that was abnormal and a measurement in the group that was normal. And so we can plot that, and this is in the Wishburgh book, these diagrams. And we're going to create a thing called a receiver operating characteristic curve. Remember, that was right at the bottom of the technical evaluation list, right? Let me put this up here. Okay. So, sorry, let's go back here. We're going to define sensitivity and specificity by the end of this argument. Okay, that's what we're on this slide for. And this probability density function gives the number of abnormals in my population and their measurement in my test. So this is like an ROI on the tumor, or this could be a confidence measurement by the radiologist. Right? They could just say, I give this person out of 1 to 5, I'm calling this a 5. That is, I'm certain that this is, abnormal. And this is the distribution of those calls in the abnormals. This is the distribution of those calls in the normals. Okay. For an arbitrary threshold, right? So let's just lay down a threshold and say, you know what? Let's call anybody above 50. We're going to call them abnormal. We're just going to say this test gives me an abnormal call. And so that can be the radiologist saying, yeah, this is a 4, or yeah, this is a 3.5. But on this call, well, let's say the radiologist gives you this number, just yells out, I got a 60. So we're going to call them positive. I got a 40, we'll call them negative, right? And then this is the true underlying distribution, right, of the patients, right? The issue with this is that certain radiologists are more apt to call things abnormal than others. Some people are conservative in the sense that they don't want to miss something. They don't ever want to be on the wrong end of a decision where they say, how could you have missed that? It was right there. How could you have missed that? So they call it positive, right? Versus a radiologist who says, if I call this positive, this person's headed for chemo. I don't know. I don't have enough here to say you should start your chemo, right? So this big decision sort of weights on these things. They're cost benefit weights on these decisions. They're not just simple raw number decisions, right? And that is why this threshold in this whole milieu of imaging is quite flexible. And so some people will operate at a threshold up here where they never want to call a normal person abnormal. So the integration of this, they're always going to have the normals are down there. Some people are going to put their threshold here. Some people will put it back here because they never want to miss an abnormal. So how do you evaluate the efficacy of your imaging technique when you have all these people using it in different ways? Right? That's the conundrum, right? And this is something that is through all kind of testing, medical testing. Okay? In imaging, it's particularly hard because of the ease with which you can move this threshold, and you sometimes don't even really know how to quantify a person's threshold number. Right? So instead of a single evaluated sensitivity and specificity, right? Which are, let's look at what the sensitivity is. Remember, it's the fraction of people you call true positives out of all of the positives, right? That's your sensitivity. And so it's that box, remember those boxes? It's the true positive box divided by the true positive box plus the false negatives, because those people are actually positive, right? So it's this number here is just all of the positives, right? That's your sensitivity. The number you call true positive divided by all of the positives. So the true positives, TP for this threshold, is the integral under the abnormals here, right? And the sensitivity is this integral divided by the integral of the whole thing, right? And so as I move my threshold this way, my sensitivity goes down. As I move my threshold this way, my sensitivity goes up. The specificity is exactly the same thing using the normal distribution, right? And it's, except you're on the opposite side of the threshold. So it's the true negatives down here are called that. These guys for this threshold in the normal distribution are the false positives, everybody in here, right? And so the true negatives divided by the entire integral, the fraction of true negatives divided by all the negatives is the specificity. Okay. So normally, instead of looking at these histograms, although I like these histograms when we have them, I always put them in a paper. You use a thing called the receiver operating characteristic curve. And the way you compute that is you move this threshold and you map out a performance as a function of the moving threshold. Okay. So the true positive fraction, if I put my threshold up here, say way up here, okay, so that you had to be really abnormal to get called abnormal. So I put it all the way up there. Then when I look at my false positive fraction, I get 0. If it's high enough, my true positive fraction is 0, so I'm here. As I move the threshold back here, right, my true positive fraction, the integral under here, starts to go up, right? But also my integral under the normal distribution goes up. And so this line doesn't just go vertically, right? It moves this way too. So this is the integral, relative integral under here. This axis is the relative integral under the abnormals. So as I push that threshold, this line maps out a whole sequence of values of true positive fraction versus false positive fraction. That thing is called the ROC curve, right? If the line was right across the diagonal, that means those two distributions are lying right on top of each other. And you may as well flip a coin, right? There's no way to distinguish them. If it goes up vertically like this, there is some space where the integral under the abnormal is accumulating and you haven't hit the normals yet, right? You're still going up on this vertical line. That's great, right? And then it turns the corner. The number that's given in papers to say, like, you know, what is the relative performance of one technique over another is the area under the AUC curve. And it's, everybody gets 0.5 as a gift. And then the amount you earn after that is the amount between this line and this curve, right? And so the area under the curve can be 0.8. That means 80% of this square is filled up, right? And where you want to operate is your choice, right? So one reasonable place is, what is the closest distance I am to this corner, which is the perfect place, right? So I get no false positives and I collect all the positives, right? So that's that when all the boxes are on the diagonal. And so that could be where you want to operate, right here. That's truly where you do. However, your closest distance to that could be another choice. Say, well, we'll just pick this threshold. That's where we'll operate. Clinicians operate up and down this curve. And so when we write papers and we evaluate our imaging technique to say predict somebody's going to have an event or predict somebody will respond to therapy, normally an AUC curve shows up in that paper. And a very good AUC curve will have anywhere above 0.75 for its area, right? And then if you go from 0.75 to 0.8, that's actually it actually turns out to be a fairly big deal. So that's sensitivity and specificity. With those same boxes, you know, let's go back to our boxes. With these boxes, we're going to fill these boxes up with numbers with our study. We can calculate the positive predictive value and the negative predictive value. And the formulas are similar, but, you know, it's a little bit different. Just like I said, if you're in a room full of people called positive, and so you're in the room full of the true positives and the false positives, what is the fraction of the true positives in that room? Right, that's a different number than sensitivity, okay? And negative, same thing for the negative predictive value. Any questions about those? This is a number you should give. We always give this also in papers, you know, to give you an idea. If you get a positive call, where are you at, you know? Here. So how do you do it in real life? I mean, what is the problem with this? There's a word on this slide that has a high presumption. Does anyone see the word that you're presuming you have? Yeah, truth. Who the heck has the truth, right? And so it normally you don't have the truth, which is a problem, right? So you have maybe an alternative, much more expensive imaging method that's been shown to be very reliable, very good. That's not called truth. That's usually called gold standard, which most of the time is like bronze standard if you really want to, you know, go there. And then you have some horrible situations where, like, for generations, people have been doing a measurement with, say, echocardiography that is really bad at this particular measurement, but that's the only way they could do it. And then you come up with a new way to do it with MR or with CT, and all the reviewers say, oh, you gotta validate that with echo. You're like, validate it? You know, what? You know, but that's the only thing they can do, right? Because the physicians have learned to use that. And so this is a problem. This would be an interesting project, and that is, if you had a bunch of clinical scans, can you add digitally into those scans an abnormality that you could then test somebody would detect, right? And so I have 100 scans, and I'm going to put 25 of them I'm going to make abnormal by putting a lesion in them, like a lung lesion or something like that. And then I'm going to give it to my clinician and say, can you see those? You need to add them at some, you know, point in the imaging process that makes sense and that is based on the physics of the situation, such that that is what that lesion would look like, right? And if you just try and like blop it in with Photoshop, you probably won't get the right look, like for the underlying truth. So you need to move back into the process and say, well, if I had a lesion here, it would look like this in the raw data. Now the imaging process itself will modulate that signal out to the image. It'll add the noise, it'll blur it, it'll do all the things that would happen to that signal. Can we see it? And then you can vary the amplitude of the abnormality to see what is the threshold of seeing it in the picture. So a lung tumor is one thing, perfusion deficit in SPECT maybe would be one thing. The other thing you can do is you can just make a full phantom that is a completely digital representation of a human, and then change that thing and image it in many ways and see which one is better. That's really, really hard. And I actually I'm skeptical of results that come out of those phantoms, because you just adjust the quality of the phantom and the quality of the whole simulation until you get a result that kind of looks reasonable. Say, okay, there we go. It gives you an idea of the range of, say, radiation you would need to use or something like that, but it's not the clinical situation. The simulations that when I read in papers that I think are reasonable are the ones that start with clinical data and modify the clinical data and then push it through, right? So without truth, we have some issues. And so one way of evaluating a imaging method and putting gradations along that ROC curve is to ask clinicians to give the probability or their confidence that it's abnormal, right? And so if they give you a 4, right? So they think it's there's no question, this is positive, right? In their mind, there's no question. And you know, of the 16 cases they gave it for, 14 are truly positive, because you knew that person got lung cancer later, so you know it's positive. So one way of doing this is to wait and see if that disease that you're trying to detect actually comes to pass. Breast cancer you could do that with, etc. And then some they give a 3, and then 6 of the 9 were positive. The ones they gave a 2, 1 of the 7, and 3 of the 12. And so that you can then integrate these numbers as you go, and you can make an estimated ROC curve, okay, with those confidence levels. And you can assume the underlying distribution is normal and then fit that to a curve that is 2 normal distributions with a threshold line. And use these as data to make that fit, right? So then you get an estimate of the ROC curve for your technique. There's another issue with all this, and I have to finish by 10:50, right? Yeah, or 10:45, okay. And that's bias. I'm not going to pause here, but if anybody wants to read a few papers on bias in clinical trials and explain to the class how you can rig a trial such that everybody coming in the door is much simpler problem than having a random set of people coming in the door, then it's worth doing. It's a lot of trials published are not true trials, right? This, on the other hand, is a true trial. This is called ischemia. I'm going to spend 2 minutes on it. And ischemia was, let's take everybody that truly has ischemia. We will validate they have ischemia. And that group will split into 2 groups, which we'll do in, PCI or stents in one group and optimal medical therapy in the other only. Courage, if you recall, gave a negative result. There was no difference between the 2 arms. But the complaint about Courage was, well, maybe there was a lot of people in there that they didn't have ischemia, so you were treating nothing, right? Let's change the group coming in the door to a group that we know has ischemia, and let's see what happens. Obviously, then the PCI people will do better. Well, no. It turns out the result here is that no difference between invasive PCI plus medical therapy versus medical therapy only, right? In doing this, it turned out that they used CT as well as stress to get a definite perfusion problem. So it gave imaging people a great platform to look and see what's the difference between CT and perfusion, right? Because you have all this data all of a sudden, right? Huge amount of data. 8,500 people were brought in, but 3,300 were excluded. And A lot were excluded because on their ischemia test, they didn't have ischemia. Okay, so their nuclear medicine was normal, even though every other thing looked like they would go on the trial. And then a bunch were excluded because they didn't have obstructive coronary artery disease on the CT. So now we're really loading up this group, right? We have a positive ischemia test with nuclear medicine, a positive obstructive coronary artery seen on computed tomography. So this group is a very special group. In order to eliminate possibly unnecessary invasive therapy, like putting stents in people that truly don't need it, they're double validated, right? There's not only ischemia, there's a target you could open, right? And here are the numbers. 3,800 close to that underwent, excuse me, CTA. So we have a huge number of scans to test here. 2,500 got PCI or cabbage, and 2,600 got drugs, just drugs. And here's the end result. This is the composite outcome over 5 years. This is the cumulative incidence, like events of they got myocardial infarction, they died for any reason, they wound up back in the hospital with a heart attack. And the conservative strategy, drug therapy, grew like this in terms of probability or the cumulative number of people that had events. You can see the invasive strategy had high events earlier, which makes sense because you're doing an invasive procedure. But then it seems to have a different slope than this, but it's not significant. It didn't reach significance. For death from any cause, they're absolutely identical, right? So if we're all the way down to that hierarchy at the bottom, says, well, does life expectancy change in my group? No, it doesn't. However, remember, there's two games being played here. Does life expectancy change in my group that I'm insuring versus me as a person, can I still cycle 5 miles a day? That's a different question, right? And in my group of friends who've had this done, they were unable to cycle, or they were unable to like even walk around a golf and such like that. And then post, they could do those things. So those are different outcomes, right? They're going to die at the same time as the other people, but now they're. So here's invasive strategy is better, conservative strategy, this means PCI, this means drugs. And this is just the delta in the 5-year event rate for subdividing all of these people, okay? So diabetes, if you look at the diabetics versus non, was there any difference? Nope. If it's new angina, is there any different? Nope. All right. So if this confidence interval hits 0, it's non-significant. Right? Interesting for the imaging people in the crowd is degree of baseline ischemia seen on the SPECT scan. So this is that SPECT stuff we studied, right? None or mild ischemia, moderate and severe. What were the event rates? None, the event rates 24 and 16, moderate 18, severe 14. It's like, what? Tell me that again. Right? I got severe ischemia, I got lower event rate by a factor of almost 2. What the heck's going on here? Right? And in my conservative strategy, no difference according to ischemia. These people had really abnormal SPECT scans, and these people had basically normal SPECT scans, event rates. And these were, what? That makes sense, right? You go down to the CAD, which is the CT image looking at the coronary vessel. And if they have 1 vessel disease, this is their event rate, 2 vessel this, 3 vessel this. Okay, that makes more sense. Okay, the events, the probability of having an event goes up as your severity of disease goes up according to this criterion. However, the difference between optical medical therapy and invasive, this is invasive, optical medical, still insignificant, right? However, the data look more sensible, right? So that leads to the imaging people coming onto this study. They glom on and say, whoa, we got to look at what the heck's happening here with the imaging studies, right? And so they investigate the relationship between severity of CAD and ischemia. And it's basically the same data, is that the, all-cause mortality and the ischemia outcomes, there wasn't really a significant difference. And then when you look at CAD severity by cath, 3 vessels with greater than 70%, you see these are kind of complex because you've got a lot of geometry. You say, how many lesions do I have? Where are they? This is the most severe. You've got 3 lesions or 3 vessels, each with a lesion, or you have 2 vessels with a lesion and one of them is the proximal LAD. So that's a serious thing. And that says you got way higher risk than this person down here that doesn't have disease, right? So that was an outcome for the imaging people. It's just like, well, maybe we shouldn't do SPECT at all. Let's just do this, right? And so the one interesting outcome here was that for the folks who had the most severe disease by CTA, so when you looked at it, had the most lesions, there was a difference in basically cumulative incidence for conservative versus interventional. So interventional, these people did have a lower event rate, but it was just a little bit significant, right? It's not huge, right? So that's taken us all the way down that hierarchy table to like what are their outcomes, right? And I won't pause on this, you can look at the slide, but this is just the baseline ischemia by SPECT, CAD severity, and it, there's a huge correlation here, nothing here. It's inverted. It's the wrong direction. And then we won't look at this, but another way of looking at those 2 imaging modalities is concordance. Take the same patient, what's the call using cath, what's the call using CTA? Are they exactly the same? They are not. And this is a concordance matrix. These are the ones that are the same, and only 55% of the cases got nailed with the same call, right? On both the CTA and the coronary cath. And it's kind of, here's a lesion here on the CTA, I'm sorry, on the coronary cath, and then this lesion on the CTA wasn't called above 50% for the left main. Now 50% means you look at this distance and you look at that distance and you say, is it greater than 50%? And they didn't call this. On here they did. Which one's right? I don't know, right? I mean, it's concordance, right? It's not, this is usually taken as ground truth, right? But there's reasons why it could not be true. And then again, here's a lesion here in a left main. This one is the same lesion on the CT, but that wasn't called 50%, right? These are just the examples where they didn't. Now this one's weird. Here's the catheter. This is the left main going into the vessels that go off it. Look at that thing. That's a obvious 50% lesion. It doesn't even show up on the CT. So I don't know what happened there. I don't know how far apart these studies are, but that's interesting. So anyway, that's where we'll end there. That's sort of a quick introduction to like comparative testing of different imaging techniques.